Hi, Egil, and
Hi.
welcome to this interview. It's
Well, thank
really a
you.
pleasure to have you here.
Well, thank you so much.
First of all, Egil, why don't you start by telling the viewers who you are?
Yes. Well, thank you, Elsa. Well, I'm a doctor, a medical doctor, in field of pain medicine. I've been doing pain research for many years, and I started out as a general practitioner, and then also became a psychiatrist working with somatic issues, problems actually. So I've been in the chronic pain field also as a psychiatrist. Most of all, the last years, I've been a specialist in pain medicine, which in Norway we call it a subspecialist. So all kinds of specialists can be also a pain specialist. So that's my background, and now I'm doing clinical work as a pain rehabilitation doctor, but also a pain treatment doctor. But most of all, as a professor, and doing research for chronic pain. That's the most what I'm doing right now.
And how did you get into this field? What was it about it that interested you?
Well, it's a long story actually. If you're asking me about the professional work, um, that's probably in when I was a general practitioner. I had every day lots of patients coming to it with the chronic or acute pain problems, and I figured, well, this is so complex. I have to study it more, and it's not easy. It's not just to give a tablet or just a quick fix. Most of these problems are complex, and that triggered something in me. Also, I was curious about how to do this, and then later on, I went to work at the University Hospital Pain Center, and also did some work as a researcher and a PhD, uh, and then, as I said, as a researcher and a professor in medicine, I'm continuing on this work.
And you do have a lot of patients with, among others, fibromyalgia, isn't that right, Egil?
Yes, that's right. And actually, my PhD thesis was about the fibromyalgia and also some clinical pain experiments, but most more for clinical work as a fibromyalgia.
Hmm.
And then I still have some as in the pain center and also in the pain rehab center. That's two different places I work. So
Okay.
yeah, and I also have some contact with the patient association, Norwegian Association of Fibromyalgia, and I'm a medical advisor for them, and
Mm.
I have some collaboration with some projects for the fibromyalgia patients.
And how would you, Egil, explain what fibromyalgia is to someone that has newly been diagnosed?
Um, I will first of all take some good time,
Okay, good.
plenty of time. It's some misunderstandings from before. I'll concentrate about a few points. Uh, the main point is that the fibromyalgia is a very real condition, and it's a condition belonging in the uh, somatic nervous system. So it's not the psychological disorder. It's we call it most of all in the central nervous system. Of course, I had to put this in a way which is uh, for lay people, not for experts. So I'll tell them it's a real condition and it's sensitivity, increased sensitivity. in the nervous system, especially in the central nervous system.
Okay.
And that's one point. And it's also it's not a psychological disorder. That's also that's implicit in the first point. And then I'll say it's well, it's more about treatment and prognosis. We could say it's now different uh, stages or different categories. So if you have fibromyalgia, it's not yes or no. You have different um, parts, different grading. Some are mild and moderate, and more you have more serious uh, conditions as well. So
Okay.
it's not yes or no. You can have different scales,
Yeah.
and that also includes that you can get better, but you also can get worse. So you can go from, for instance, mild or moderate, and you can, if you're unfortunate, you can it can develop into more serious. But also you can turn the other way around. So if you have
Mm.
a serious or a bad fibromyalgia problem, well, you can go the other way and you can go more into the moderate or mild, or even get rid of the whole fibromyalgia. And that's something new. It's a new way. So
Yeah.
I think that's very good news. And also we'd like to mention that fibromyalgia is an interesting and very important topic in the International Pain Society, the big conferences. It's called International Association of the Study of Pain. And
Mm.
technology is very interesting for the participants there because it's a complex and it's a prototype for, we call it nosoplastic pain. Um,
Okay.
well, the point is it's very interesting because some doctors say, "Oh, it's nothing. No, it's don't understand. No, it's nothing at all."
Yeah.
Uh, but if you talk with people working in the pain field internationally, as I said, it's very important and it's a very interesting condition to do research on. So it's
Exactly.
a much higher status in this research field
That's
than
very
among
interesting.
some. Yeah, because I think some of the patients they have feeling that they are not validated, and some doctors say it's nothing, and so on. So that's not the case in the researchers society.
That's very good news then. You said a little bit about it not being a psychological condition, and I know that that is one of the misconceptions that it is something psychological. Uh, are there any other misconceptions about fibromyalgia that you know about?
I'm not sure. I just have to say that it's not a psychological condition, but if you have, of course, if you have pain problems, you will get also psychological problems. And
Mm.
what's it, the hen and the egg is very different in some conditions. And
Mm.
the most problems is you have a sensitization, and you can have physical trauma, you can have immunology. That can also, of course, get worse if you have psychological problems as well. That could even get it worse. So what's the cause? It's complex and it's
Mm.
multifactorial. But if you ask me what did you ask me? Please again.
Now, if there are any other misconceptions out there about fibromyalgia.
Well, I think the misconception is I already mentioned a little bit about because people think it's a muscular disease or
Mm.
it's a rheumatology disease. It's not that's not really correct. It's in the nervous system. So
Okay. Yeah, that's
traditionally, it's been conceptualized as a muscular or rheumatology disease.
mm.
Now it's more into the neurology business.
Yeah.
So that's a misconception, I think, is because you don't find anything wrong with the muscles or tendons or the tissue. Um, so I think that's a misconception.
Okay. That's a very good.
And
Um,
another one is that it's, as I also said, that's yes or no. That's a misconception. Some people think, oh, now I have got it, and I never, it can never be any better, or I will
okay.
never get well again. So that's a misconception. You can get better, and
Yeah.
even totally well.
Okay. And as we know now, there is no medical cure for fibromyalgia. But what can you do if you have gotten the diagnosis? What can you do yourself to get better?
Well, first of all, I will have a good examination. As I said, you can get the diagnosis. Maybe you have a mild fibromyalgia or moderate, and then you treat it differently than if you have a more serious or very serious fibromyalgia. So, that depends on what kind of fibromyalgia you have.
Yeah.
And then let's say you have fibromyalgia in moderate. Maybe it's enough to you have to look at the risk factors and what to say perpetuating factors, what will perpetuate the symptoms. Maybe it's bad sleep. Uh, maybe is some matters. It could be if you have a bad physical condition, that will also get it worse. And of course, if you have some problems, economical problems, relation problems, issues with at work, and so on. Maybe social problems, you don't get along with your boss, so stress, all kind of that stress your body will also stress your nervous system. So it's not psychological, but all kinds of stress. If if physical stress, mental
Mm.
stress, so all kinds of too much is getting it will get it worse.
Yeah, exactly. And um, which treatment approach has the best long-term effect?
Well, I was starting to answer your question. Maybe I didn't answer your last question completely because if you have fibromyalgia, you have lots of different approaches. And let's say if you have a bad condition, serious fibromyalgia, I think you should have both medical and non-medical treatments.
Mm.
So, uh, well, first of all, you need to, as I said, look at your sleep and maybe you need some medication
Mm.
against both sleep and pain. Um, and it's not the traditional medication. You can't use medication as they use against muscular pain. You need medication against pain in the nervous system. And that's
Mm.
other medication than the usual ones. For
Okay.
it's not you cannot use morphine and opioids, and it's not effect of ibuprofen and paracetamol. That's the traditional one. So you need to have a doctor that understands it's in the nerve system. So you need, for instance, amitriptyline, nortriptyline, pregabalin, gabapentin, duloxetine, and so on. You have different medications.
Mm.
That medication, and then for non-medic, medic, med, non non-medication, you also have some approaches. For instance, the best is You work with the stressors and trying to calm down your automatic nervous system. Uh,
Mm.
Turn down the switch, and then you also would have profit if you could do some exercise, both aerobic and strength exercise. Uh,
Mm.
most the best would be aerobic exercise. That's conditional increase your um, condition capacity, um, and but you need to do it very carefully.
Mm.
So if you have a very bad condition and poor strength, you can't do lots of miles and lots of heavy weights. You have to start where you are
Mm.
and take it gradual. If not,
Mm.
you get worse. For instance, you get lactic acid, you get anaerobic uh, exercises, you will get more lactic acid in your body.
Okay.
So you have to take it very slowly, and I would prefer that you have some to help you in the first part
Mm.
of the treatment. So exercise is important, but you need to do it properly and gradually.
Yeah.
So it's exercise and then relaxation. You can mental exercise, sleep, medication. So it's very multi disciplinary or lots of factors. You have to work on all those. That depends on how serious your fibromyalgia is.
Mm.
If you have a very mild, maybe you don't need so much. Maybe just sleep and a little walk and some relaxation exercises. Maybe that's enough. So
Okay.
if it's very
Very good.
serious, maybe you need a referral to a specialist care.
Mm.
And
Exactly.
most of these is in the general practice of primary care. So depends. You have to go to a specialist or even a multidisciplinary center if it's
Mm.
more serious.
That's very interesting, Egil, and I know that you have been training a lot of patients. Um, you actually touched my next question here, which was the three pillars for managing this diagnose, which is both what you can do for yourself and what your doctor can do for you. Um, how would you say, how important is it to track symptoms and patterns on a daily basis? What is
Mm.
your take on that?
Um, in your questions, I think I heard two questions. You asked the three pillars,
Yes.
and then how important it is to track. I think I'll answer the pillars first, and that I think it's very important that three most important things. I think it's very important to validate the patient.
Mm,
A good listener. If not, you can't get achieve anything. And then, of course, the next is you need an alliance
mm,
from you and the patient, as me as the doctor and the patient. You need to have a good alliance so you agree upon the goals.
mm,
Uh, and the third is, I think, a treatment should be based in best practice or research. What's in the research? So you don't invent the wheel. You have to need to be based on what you have a clinical best practice and
mm.
what's from research. So
Yes.
so that's about the pillar, and then the tracking. Um, well, that's a good question because um, uh, one of the approaches is that you shouldn't track your symptoms all the time. But then again, you need to have this alliance and validate the patients because
Mm,
say to the patient, don't track your somatic symptoms. Many patients will feel that you're not validating them.
Exactly.
So, oh, he or she, the doctor doesn't understand anything. I have to speak more and more. I have pain here and pain here and pain here. And I go all the day and I try to explain, but they never listen.
Yeah,
So,
I think that's quite
but
common.
yeah, but you know, from research that if you talk too much, it will increase the nerve system mechanisms,
Mm.
and the pain system also get worse. So that's you should not ignore the pain, but when you have chronic pain that's more than 6 months,
Mm.
you should also do some alternative uh, things and behavior. It will not benefit you if you are tracking symptoms all the time.
No, exactly.
Actually, that could be more anxiety and stress. And a lot of patients, they are getting worse if they are tracking too much. Of course, in the acute stage, before 6 months, you need to describe it very carefully,
Mm.
so you can examine the symptoms and try to find out if it's something objective findings. Uh,
Mm.
but after in the chronic pain stage, it's not so beneficial.
And
Oh,
now you're talking about tracking the pain, but what about tracking, I mean, like sleep and stress and activities that you do?
yeah, yeah. It's I won't say it's um, all or nothing. I think it's you should track some, but if you are able uh, to observe, be curious about them, not if you're not getting anxiety reactions, it could be beneficial.
Mm.
Um, so you can have monitor your of course, you can monitor your sleep, and you can monitor weight. You can monitor all kinds of stuff. But too much and too little, it's not so good.
Okay, so you have
Uh,
to find a balance then.
yeah.
Uh, uh, what do you think characterizes patients who finds a balance, who finds a better balance in their everyday life?
Um, I think um, overall, many of those say to me that they have a better life. And even though the pain hasn't decreased so much as they had wanted,
Mm.
they can go on with their life, because some are setting on hold your life, setting on hold, and they say, okay, I have so much pain, I have to wait till I get the free, to get rid of the pain. Maybe then I can invite my grandchildren and so on. And maybe then I can be with some friends, but I have to be better first. But we try to tell them, maybe I know we understand, validate that you have this problem, so but maybe you can try to continue with your life, and lots of these, if they find a balance,
Mm.
they will have a better quality of life and
Mm.
also daily function, yeah, in spite of their pain. But it's very, as again, it's very important for the therapist to validate. You know, we have pain. When
Mm.
you should go out and be more active, it does not mean that we don't understand. It doesn't mean that we don't understand your pain, but
Mm.
it's I think it's possible to do a little bit, and then I think also the pain will get less and get a relief more
Mm.
as the time goes by.
Exactly. That's a very good tip. Um, a lot of our viewers with fibromyalgia has met healthcare and has different experiences with that with professional healthcare.
Mm.
Um, what do you think that healthcare, you being a doctor, what do you think other healthcare takers should do differently?
Well, that's a very good generalization because some
Absolutely.
some some colleagues are clever and others are more ignorant. So I'll try, and I've been doing that for many years, and try to get the colleagues to understand what fibromyalgia is,
Mm,
and it's very important, and it's something you can do something about. Um, Many of doctors and also maybe other physiotherapists and so on, maybe they feel they can't do anything and they get frustrated. It's it's very good for a doctor, a physiotherapist to say, "Oh, I made it. I could cure his patients." If they feel they can't do anything, it's the motivation goes down.
okay.
So I'll try to tell them what it is, and you have different stages, and you have treatment. And if you have treatment, if you don't have treatment, you also have rehabilitation.
Mm,
It's something important. It's something you can do. It's one thing. At one point, I forgot previously that fibromyalgia could be coming with another condition parallel.
mm,
So if you have fibromyalgia, you can have another conditions as well.
yeah.
For instance, migraine. You can have rheumatoid arthritis, uh,
Mm,
different conditions, and it's very important that you can have both. And that's also a misunderstanding because some colleagues they think that okay, fibromyalgia. That's if you don't find anything else, okay, you can call it fibromyalgia because we don't know what it is. It's just okay. It's a big bag there, and I put everything we don't know. But the point, uh, it's very good defined, and you can have it along with other conditions.
exactly.
And then, but the point is that you also need two different approaches because you don't treat, for instance, rheumatoid arthritis the same way as you treat fibromyalgia. You have two different algorithms.
Okay. Well, it was very good that you said that fibromyalgia is something that's in the big bag. If you don't know what it is, it could be that, and it's very good that you said otherwise, because I know that that is one misunderstanding.
Yeah,
Also,
it's
yeah,
a huge misunderstanding. So, okay, we need to talk with them and these doctors, and then I know lots of them. They say, "Oh, I don't want a new diagnosis. It doesn't help anything. Why should they have this diagnosis? It's just nothing, and I don't. It doesn't help me, and it doesn't help the patient." They say. But I think it will help the patients, and I tell them, as I said, they have some treatment algorithms, both medically and non-medically, and you have to be aware of them. And then
yeah,
you can improve. The patient can get much better
mm,
and get totally well. So that's something you have to work on. And we have courses and write in journals and so on, and talk with people. And it, very slowly, I think it's getting to improve.
yeah, that's good. Um, how long has fibromyalgia existed, Egil? Or I
Well,
mean, the diagnosis, not the
yeah,
disease. Hmm.
yeah, I know. I'm academic, so I could say it's been existing for 5,000 years.
Yes, it's a very
But
good
in
answer. Hmm.
yeah, because the symptoms have been there as long as you have people,
Yeah.
mankind. But of course, in modern times, um, most people start about 120 years ago,
Mm.
approximately 1904 or something. But it's very difficult because it was described also in the 15th century. They called it diffuse rheumatism or something. But in modern times, 120 years, they called it fibrositis, fibrosis, in 1904, I think. And then later in 1976, they changed the name to fibromyalgia. And you have all these criteria and definitions been come and going. The most important is from 1990. It was for many years, and it was revised in 10 and 11, and now 2016.
Mm.
So I almost forgot what you asked about, but
Well, you still answered the question. My question was how long has it existed, or not the disease, but the diagnosis.
yeah.
Uh,
Yeah. So the
but
most contemporary diagnosis has been from 2016,
yeah,
and before that in 1990, what was the most used one.
yeah,
So I know many doctors, they still are thinking in the 1990 criteria, and
okay,
that's not valid now. So 2016 is what is
okay,
now. Yeah.
okay, very good. Um, uh, to start closing up this conversation, it's been very interesting. But what do you hope that people will take from this conversation that we had today?
Well, I think the um, major point is that fibromyalgia is very important and it's real.
Mm-hmm.
It's in the nervous system. And nervous system is, as you know, very complex. So
Mm.
it also it will be influenced by the automatic nervous system, and could be turned both up and down. And in the therapy, you could turn it down. So the treatment approach is to try to turn down the increased sensitization and activity in the nervous system.
Mm.
And then you have to work on different uh, issues. As I said, both sleep, pain, capacity, physical capacity, and all the biopsychosocial aspects. So that's why it's so difficult. But it's very important, and it's a real disease, and it's very interesting among researchers. So we are following it very closely on the meetings and conferences, and I think it's a good prognosis for many of you.
That's very good. Do you
Mm.
have anything you want to add?
Uh, no, I'm not sure if I have anything more to add. Um, I know lots of you have been in contact with the healthcare system, and when I have patients, I give them suggestion on literature, um, and it's literature out there both for the professional healthcare providers, but also for the patients. And you could have a communication with your GP, for instance, and together you can talk about this, and you can show also the doctor what's out there. I know some doctors are very proud that now don't tell me anything. I know this, but if you're smart, you get a good conversation, and maybe also a good work together, and that's very important. It's not so easy for both patient and the doctor, that you need to have this alliance.
Mm. Very, very good. Thank you so much for coming, Egil.
Mm-hmm.
It was a pleasure talking to you.
Mm-hmm. Well, thank you, Elsa. It was nice talking to you as well. Thank you.
Thank you.